Hoş geldiniz öncelikle. Ben de panel...
Welcome everyone. This is the last presentation of this panel. And in this last presentation, I will discuss adult ADHD and comorbidities from the perspective of impulse control disorders. I will deal with neurobiology as well, and some other psychiatric disorders that are important in adult emergency diagnosis. As you very well know, adult ADHD manifests itself with inattention, hyperactivity, and impulsivity. 50 to 70% of childhood ADHD cases are proven to continue until young adulthood. A prevalence study from the United States shows came up with a rate of 4.4%, but only a few of these patients are treated. Subtypes are as you see them on the slide. They're predominantly inattentive, they're predominantly hyperactive or impulsive, and there's also a mixed type. There were 18 diagnostic criteria in DSM-4, and in DSM-5 they did not change. 3 of them show impulsivity symptoms. Blurting out an answer before a question has been completed, trouble waiting your turn, and interrupting others are some of the symptoms. But how is the prognosis of ADHD? As we move from childhood to adolescence and young adulthood, hyperactivity and impulsivity symptoms are reported to be significantly reduced. The drugs, animal models, and neuroimaging studies on ADHD patients show us that the frontostriatal and the frontocerebral network plays a role, as well as the dopaminergic system. The dopaminergic system in these individuals is hypoactive, which causes an impairment of executive functions. This leads to impulsive behavior and indifferent attitudes, as well as lack of empathy. Frontal lobe functions are very important. They're related to dorsolateral prefrontal cortex, for example, because it is responsible for attention, working memory, planning, organization of a task, function, and functions related to new information. Orbitofrontal cortex, on the other hand, ensures regulation of emotional stimuli and inhibitor control. DLFPC damage leads to apathy, lack of motivation, disinterest, and insufficiency, and OFC damage leads to socially inappropriate behavior, increase in motor activities. It is believed that OFC might play a role in one of the subtypes, for example. Here you see the dopaminergic pathways that we all very well know. According to the dynamic developmental theory of ADHD, hypofunction in one or more of these pathways causes dysfunctioning. Mesolimbic pathway dysfunction, for example, leads to delay aversion, hyperactivity, and impulsivity. At mesocortical, there's decreased planning, and motor function is also reduced. Mesolimbic dopamine pathway is also known as the reward pathway. From the ventral tegmental area to nucleus accumbens, and from there to the prefrontal cortex, the mesolimbic pathway sends reflections. Food, water, sexuality are the primary rewards, and the secondary reward responses are also reinforced by this pathway, such as response to money, for example. Decreased ventral striatum activation during reward anticipation has been also seen in studies of mice. This also shows that nucleus accumbens plays a role. There also seems to be decreased ventral striatum activation during reward anticipation in fMRI studies, and there seems to be a negative correlation between VS activation And genetic studies show that population and family-based studies revealed association between the 7-repeat allele of DID4 and novelty seeking. Novelty seeking has to do with impulsivity. These individuals are impulsive, excitable, quick-tempered, and features that are seen most commonly among ADHD patients. But as I said before, impulsivity is not unique to ADHD. It can be seen in addition to many different psychiatric disorders. Here you see ADHD and other comorbidities that are important in the diagnosis. In the second part of my presentation, I will go through these one by one. The prevalence of BPD in adult ADHD and adult ADHD in BPD have very close rates to one another. Lifetime presence of ADHD is higher in men than in women. When there is comorbid ADHD, the course of bipolar disease is worse because there's an earlier onset, more frequent affective episodes, suicidal attempts, and violence and legal problems. They have some comorbid symptoms as well, such as hyperactivity, distractibility, emotional lability, and impulsivity. However, in bipolar disorder, these are seasonal or they're seen in certain phases, such as mania. There are also some other symptoms, such as grandiosity, for example. These are most commonly seen in bipolar disorder. Well, these are now defined under DSM-5 in the new classification. Oppositional defiant disorder in ADHD is about 10%, but in those individuals that come to the clinics, this rate is even higher. Intermittent explosive disorder. Here, ADHD prevalence seems to be much higher than in controls. The prevalence of comorbid antisocial and borderline personality disorder in adults with ADHD is 10 to 13 times higher. In clinical samples of borderline and antisocial personality disorder, 35 to 65% received ADHD diagnosis during childhood. Impulsivity, emotional lability, and hostility are some other comorbid symptoms. Differential diagnosis, these symptoms are less serious and intermittent in ADHD. In borderline personality, there is also dichotomous thinking, abandonment fears, self-injurious behavior, and chronic instability. Antisocial personality disorder, of course, has some comorbid symptoms with ADHD. However, arrest history is more pronounced here, and lack of remorse is only specific to antisocial personality behavior. This childhood behavior also predicts adult criminality behavior. Addictions. The estimate is that around 10 to 25% seeking treatment for addictions, regardless of the type of addiction, display ADHD. There are comorbid systems such as impulsivity, for example, and this goes on to show that the diagnosis is usually in favor of addiction, which means ADHD is usually disregarded, but they're very often comorbids. In adults with ADHD, the risk of substance abuse is 2 to 4 times higher. Lifetime prevalence of it is 36%. And in substance use disorder, patients, adult ADHD is higher than in normal subjects. There's a higher severity of substance abuse in ADHD patients, and ADHD patients are less likely to abstain from drugs. those who apply to voluntary therapy still have a higher rate of ADHD among themselves, and childhood behavior may predict later cocaine use. Pathological gambling. There's a strong correlation between pathological gambling and the behaviors linked to ADHD in childhood. Subjects suffering from ADHD in childhood and continuing on to early adulthood have a greater risk of suffering from gambling problems. And in pathological gambling, there's a very high rate of adult ADHD. The rate is 20%. Recent studies show that 26% of pathologic gamblers have a history of ADHD. They have severe gambling problems. They have a higher level of gambling-related cognitions, higher frequency of psychiatric comorbidities, and an elevated risk of suicide. High-level impulsivity constitutes risk factors for comorbidity with ADHD. Here are some other behavioral addictions. There are no adult studies for internet addiction, but adolescent studies show that in internet addiction there are more ADHD symptoms. Same goes for compulsivity of people with internet addiction. So as a result, approximately 50% of the individuals with ADHD have one form of psychiatric comorbidity. Approximately 45% of the adult population is impaired with ADHD, and less than 1/3 of these adults are diagnosed. Therefore, being aware of the comorbid psychiatric conditions and the correct differential diagnosis are very important for an efficient treatment of ADHD. Thank you.